Cambridge in the London. And first pancreatogram was taken, and they defined that a normal pancreatogram is filled up to the second generation of duct. It fills up to the tail of the pancreas, and there should not be any blurring, no air bubble, no parenchymal opacification. Because if you do a parenchymal opacification, risk of acute pancreatitis is very high. And I think now taking the pancreatogram for the diagnostic purpose is no more exists. You only do a pancreatogram when you want to do the pancreatic endotherapy. Let's start with the history. Michel Kramer, if you look at his handwritten, the first 10 ERCP for the pancreas, he was failed in the 6th and one patient died. But he never loses his hope and he continued with that. And I think today, Michel Kramer is the father of pancreatic duct cannulation as well as pancreatic endotherapy. As I said, the diagnostic pancreatogram is no more exist. It is replaced by the MRCP. We only do the pancreatic duct cannulation when you want to deal with the calculi, strictures, if there's a leak in the pancreas, or in a patient of fluid collection, chronic pancreatitis with the fluid collection. When we look at the anatomical perspective, for the bile duct cannulation, you cannulate at around 11 to 12 o'clock position. And for pancreatic duct, you cannulate around 1 to 2 o'clock position, where the pancreatic duct opening start. Now, the most important thing, the God has not given the papilla always in the one form. There are different type of papilla. There are different position of the papilla. And sometimes because of acute pancreatitis or chronic pancreatitis, the papilla may be present in the different form or in the different situation. You may not able to focus the papilla and face in front of your side wing endoscope. So if you look at the Michel's classification, the type 1 variety where there is a common channel of around 1 to 1.5 centimeter, which is the most common site. But you don't find always such kind of position. So when you want to cannulate the pancreatic duct, the most important thing is try to position your scope and to spend the time knowing about the ampulla. It is better to spend the time at least for if the ampulla is in the difficult position, rather than spending 20 minutes on cannulation. I will prefer to enface my ampulla. I may spend 10 to 15 minutes. If you enface in front of your duodenoscope, the chances of pancreatic duct cannulation is very high, and it is not going to take more than 3 to 5 minutes. But if the ampulla in the different position and you are trying from the difficult angle, then it takes long time. You fiddle with the papilla more, risk of pancreatitis goes very high. So those who are doing ERCP, I suggest the position of the scope that I always feel is the middle distance, that is around 60 centimeter from the incisor, or the short scope position is very important. For the minor papilla, a long scope position or a semi-long position is very important. Position an ampulla in such a way that when the accessories come out from the duodenoscope, it goes towards the ampulla, rather than you keep on changing your direction of your hand and you try to manipulate in such a way that it is difficult to get the access. So first and the most important thing is spend time focusing the ampulla, which is end face, as well as position of your scope. Second important thing is correct your axis. When your accessories goes towards 11 o'clock, it is towards the bile duct. So before that, make the small wheel of your duodenoscope on the left side that will direct towards 1 o'clock position. Correct orientation, correct angle, that is more important before embarking on ampulla for the cannulation. Third important thing is choose the correct accessories while cannulating and be gentle and respect the papilla. I think pancreas, especially in a patient of normal pancreas, when you are trying to fiddle with the ampulla, it is very important to respect. If you don't respect the papilla, you may come across with a difficult situation. So how to position the scope? If you see the middle photograph of the fluoroscopy, that is a right short loop position. And how you do? From the first part of the duodenum, you lock the right knob on the right side, make the big knob towards you, and give a clockwise torque and focus the ampulla in such a way that your ampulla is directing at around 11 o'clock in front of you. Once you have end-face in the right direction, then choose your accessories. And as I said, the bile duct is towards 11 o'clock in position, as it is seen here. And the pancreatic duct is around 1 to 2 o'clock position. So what will you do? With the small knob, you make it on the left side. So your accessory is going to face towards 1 o'clock position, and you can cannulate. Now, what is another important thing is, what accessories are required? Either you use the standard cannula or use the sphincterotome. Standard guide wire, I generally prefer a angle tip hydrophilic guide wire, which is very important. And you look at it, you should learn to technique to manipulate. Either you use the device to manipulate the wire, or your technician rotate the wire with your hand. I think the rotation of the wire is very important, both across going through the stricture or negotiating into the pancreatic duct. Now for pancreatic sphincterotomy, either use the pure cut or use the blended current. It will be depend upon the personal choice. The role of needle knife in the pancreatic duct cannulation is hardly needed. And once you have cannulated, do a pancreatic sphincterotomy. If required, you can use the balloon sphincteroplasty, or you may use the pancreatic stent for cannulation of the pancreatic duct, especially the minor papilla. So this is the standard technique when you use the cannula. It is perpendicular to the duodenal wall. You introduce at around 1 o'clock position. And for the bile duct, once you engage into the ampulla, ask your assistant to both the sphincterotome, so it will direct towards the bile duct. Now, I will show you the technique. Left axis of the scope, small wheel on the left side, perpendicular to the duodenal wall. And don't try to press too much of the papilla. Engage your sphincterotome or cannula inside the ampullary orifice and tell your assistant to manipulate the guide wire. In my practice, I use the cannula, and I always do the wire-guided cannulation. One more thing which I want to tell you, if you are getting unsuccessful or if the ampulla is floppy, I generally take a small pancreatogram, and under fluoroscopic guidance, I try to manipulate my wire. But guide your assistants or guide your technician. He should not take 10 or 20 cc of the contrast. He should take a syringe of 5 ml or 10 ml maximum and use the concentrated contrast and try to use the angle tip wire. So look at here, I make the big knob on the left side and try to cannulate towards 1 o'clock position. Once I take inside the papilla, I manipulate the guide wire. If I'm not successful, I take a pancreatogram, and under fluoroscopically, I try to negotiate the wire. I tell my assistant to follow. Many of the time, because of the ENSA loop, if you are not able to do it, we put a pancreatic stent and we do the sphincterotomy or try to manipulate the ENSA loop to straighten it. And how can you straighten it, the ENSA loop? You push your scope downward, make the right knob on the right side. That is going to make your ENSA loop straight if it is small. If you have a bigger ENSA loop, then it is difficult. Now, the standard technique, again I said, make the direction at around 1 o'clock position, negotiate the wire deep into the pancreatic duct, use the endocurrent, endocut or the cutting current, And what should be the end point of the pancreatic papillotomy? As like the biliary sphincterotomy, you can do a long pancreatic sphincterotomy. That is the best way. In a patient of chronic pancreatitis, the God has given a liberty that you can fiddle with the pancreatic duct, but mind it, always use the indomethacin suppositories, hydrate the patients, and then try to cannulate the pancreatic duct. As I said, many of the time, I use the wire manipulation under fluoroscopically. Look at carefully. We make an angle of the wire. It should not be straight tip. And the angle wire goes inside the pancreatic duct. So risk of the injury is not there. You see here, the wire is angled. Again, here the wire is angled. So chances of going to the side branches are very less. And many of the time, if I'm not able to cannulate, after taking the pancreatogram with the concentrated dye, I try to cannulate either by my hand or my technician. I guide them how to rotate the wire under fluoroscopic vision to cannulate the pancreatic duct. So, one of the most important thing, cannulation is the only part of the story of the pancreatic disease management. Is only one part. We must always complete, including wire manipulation, and achieve the therapeutic goal that is required for the patient of chronic pancreatitis. Now, many of the time when you read the literature, people talk. When will you take the needle knife for the biliary sphincterotomy? Literature says 5 cannulation, 5 minutes. Somebody talk about this time, somebody talk about the number of the time you have done the cannulation. But for the pancreatic duct access, there is no standard of the definition of the how much time you fiddle. But generally, if you are not able to succeed in the pancreatic duct cannulation, my suggestion, rather than fiddling with the pancreatic ampulla, it is better to call your senior or expert, or refer the patient to a place where the more pancreatic endotherapy is going on. When you anticipate a difficult pancreatic access, that is the pre-papillary or the head strictures, or if there is an ENSA loop, or if there's a large stone in the pancreatic head, or anatomical variation, or if there is an edematous duodenal fold because of the acute pancreatitis, how to tackle it. In difficult situation, I suggest those who are doing the endoscopy, don't do a needle knife for the pancreatic duct cannulation. In a very rare circumstances, if you are not able to do it, then you should try. Otherwise, needle knife sphincterotomy is always better for the bile duct cannulation. It is not good for the pancreatic duct. We may sometimes put the stent, and over the stent, we do the pancreatic sphincterotomy. Or you put a secretine, give a diluted methylene blue, and you can see here the pancreatic juice is coming from here. Bile is coming at 11 o'clock. And then we try to cannulate with the help of the angle tip guide wire, and we go deep into the pancreatic duct. And once you have taken the pancreatogram, you can manipulate. And as I always said, tell your assistant to make a loop of the pancreas of your wire at the proximal end, so the risk of going to the side branches and the risk of pancreatitis is very less. Now, in the difficult situation, it is possible that you may put your guide wire into the bile duct and along, like we keep a wire in the pancreatic duct sometime, and we do a cannulation to the biliary duct. And if you are going repeatedly into the biliary duct, keep your wire there, and then with another cannula, you try to go into the pancreatic duct. In difficult situation and difficult anomalies, you try to use angle tip, as I said, or refer the patient to the higher center. Now, once you have done the sphincterotomy, you look at the stones. This is our paper which was published. Patient who has a 5 to 6 millimeter stone. What we do is, we do the balloon sphincteroplasty of the papillary orifice after doing the pancreatic sphincterotomy. We dilate up to the 8 millimeter or 10 millimeter with the help of balloon, and then with the help of biliary retrieval balloon, we remove the stones. Yes, there may be sometime question may arise, balloon get burst with the help of the pancreatic stone because they are speculated, but using the Dormia basket, the chances of success of complete clearance is sometimes difficult, but I think it is an individual practice. In my practice, I use the biliary balloon to remove the pancreatic stones. Now, the cannulation of the minor ampulla, this is a tricky situation. Again, the minor ampulla is situated proximal on the right side of the major papilla at around 2 centimeters. And sometimes it is very difficult to cannulate the minor papilla. And what are the tricks? As I said, the most important thing is position of your scope, making the correct axis and using the correct direction, which is the mandatory. And that is either in the long loop position or in the semi-long loop position. You can see the fluoroscopic images. Here I am in the long loop and here I am in the semi-long loop. Make the pancreatic minor papilla end face and then try to use the taper cannula with the 0.025 or 0.08 guide wire. Similarly, here, focus the minor papilla in the semi-long position. Once you have focused the major papilla, push your scope downward after making in a short position, and you can come across with the minor ampulla in front of you. So this is the way you can focus the minor papilla, but that is not always true. And what accessories you are going to use? In my practice, I use the taper cannula with the 0.025 or 0.08 guide wire, taper tip cannula, that is better, or a needle tip catheter, the short nose sphincterotome. These are the things. Again, your assistant should be able to manipulate the guide wire, which is very important because minor ampulla is very small and it is sometimes difficult, and your wire should be around 5 millimeter, 1 centimeter outside the taper tip cannula. This is a dedicated device which has a nitinol wire, especially meant for the minor papilla cannulation in a patient of pancreatic divisum. And these nitinol wires retain their shape and they are very helpful in cannulating the minor papilla. Sometimes, if it is difficult, then use the wire guided, and I sometimes use the NBI. And with the help of wire, we try to cannulate. Sometimes stent guided, we cannulate with the wire, put a stent, and over the stent, we do a minor papilla sphincterotomy. Now, in difficult situation, you can use the injection secretin. Once you put an injection secretin, within 10 minutes or so, you started seeing a lot of pancreatic juice started coming. You can see in this video from the minor papilla, the juice is coming and it is easier for you to cannulate. This is the video, how to make a semi-long position, both shown in the fluoroscopy as well as in endoscopy. You look at that. My duodenoscope is going into the second part of the duodenum. And this is the minor papilla and this is the major papilla. This is the major papilla here. Once you have shortened it, withdraw the scope a little bit. I'm withdrawing my duodenoscope. And once you reach to the major papilla, push your scope down to make it semi-long position. Look at here, I've done the semi-long position of the scope, and you can see the minor ampulla around 2 centimeter proximal on the right side. You will look at here, the minor papilla will come. So this is the minor papilla which has come. So the first and the foremost important, focus your ampulla, focus your minor papilla, position your scope in a stable position, then choose the right accessories, use the angle tip guide wire to cannulate either a pancreatic duct from the major ampulla or from the minor papilla. This will depend upon the indication. So this is a different type of cannulotome, which is handmade, has a steel tip, which is sharper, and you negotiate because it is firm and it is tapered. It is very easy to go inside the pancreatic duct. And once you have taken the pancreatogram and you know that it is easy now, then you can change to the standard sphincterotome or the cannula over the wire. As I said, take out the wire around 0.5 millimeter to 1 centimeter, directing towards the papilla, and then cannulate the pancreatic duct through the minor papilla. So this is important. A good coordination between the endoscopist as well as your technician is required. A good fluoroscopy is also required, and patient should always be sedated well. So it is possible for you to cannulate the minor papilla. This is the same video. Now, this is a video of the Rendezvous technique. This patient has a partial pancreatic divisum. We were trying, but what we have done, we cannulate from the major papilla. The wire has come from the minor papilla. Now we withdraw the minor papilla wire, and then over the wire, we put a stent and we can do the cannulation. So Rendezvous technique is possible, but it is rarely used in the day-to-day practice. This is another two-way that there is a bow shape of the cannula, but it is not commonly available. EUS-guided pancreatic duct intervention is possible, but it is to be done in a patient of altered anatomy routinely. In the routine purpose, I don't use EUS-guided pancreatic duct access. If I'm not able to cannulate, especially because of the stone, then it is better to do the ESWL. But EUS-guided, you can do the Rendezvous, you can do the antegrade stenting, or you can do the pancreaticogastrostomy, but especially in a patient of post-Whipple's where patient has pancreaticojejunostomy and it is difficult to reach there. So pancreatic duct access indication, anastomotic stricture as a pancreaticojejunostomy, chronic pancreatitis with a PD obstruction, not amenable to ERCP, pancreatic fistula, especially the disconnect duct syndrome, or failed pancreatic cannulation, where you can try EUS-guided. By my suggestion, those who are learning, never try EUS-guided pancreatic duct access. It is better only in a patient where there is an altered anatomy. Otherwise, refer the patient to your senior or to a center where the pancreatic endotherapy is done. So ladies and gentlemen, to summarize about the pancreatic duct cannulation, straight scope position, focusing the ampulla and face in a stable position is mandatory. Leftward axis of the scope by making the big knob on the left side. Angled hydrophilic guide wire is mandatory. 1 o'clock is a cannulation site. I generally use the cutting current, but it will depend from individual to individual. Pre-cut or the double wire techniques can be used, but avoid in your day-to-day practice. EUS-guided pancreatic interventions are available in a selected group of patients. Anatomical anomalies are known, and one should be vigilant about this. Thank you for the patience hearing. Should I start with the second talk, Professor Baijo?
You can go ahead with the second talk.
Should I start with the second talk?
Sure, you can go ahead.
Go ahead. So I think this is very important topic, and this is important. I would like to tell about the surgeons, those because we come across with the many patients of acute pancreatitis, or those patients who are going for the cholecystectomy. If they have a mildly raised alkaline phosphatase, or if they have a raised gamma GT, these patients earlier were sent for ERCP. But ERCP has its inherent risk of pancreatitis and perforation. So I think in 2022, ERCP to be only done in patient where there is a stone, or in patient of acute pancreatitis, which I'm going to talk, when the ERCP should be done. So the quest, if you look at 3 decades before, the human and the animal studies shows that biliary obstruction lasting for more than 48 hours create more pancreatic necrosis. And that's why 3 decades before, surgery was used for the biliary decompression, but soon the surgeon identified that the surgery was associated with the significant morbidity and mortality. And after that, 3 landmark study 3 decades before, neoptolemus, fan in the foliage. And the neoptolemus study shows that ERCP in a patient of acute biliary pancreatitis reduces the morbidity and mortality. Within few hours of that, the FAN published in NEJM, and what he has shown that doing an ERCP in a patient of bile duct stone, meaning that biliary pancreatitis, doing an ERCP may be helpful. Otherwise, in all pancreatitis, it is not required. Contrary to these two studies, Follish in 1997, he has stopped his studies because what he has seen that doing an ERCP increases the respiratory complication associated with the more morbidity or so. So, three different landmark studies with the three different results. One study shows that yes, doing an early ERCP in acute pancreatitis is helpful. The FAN study shows only in biliary pancreatitis, and Follish is it should not be done in a patient of biliary pancreatitis. So look at it. There are two schools of thoughts. One school of thought, early ERCP or emergent ERCP in a patient of biliary pancreatitis, and second school of thought, the conservative. And what are the rationale? The early ERCP group people feel that duration of the biliary obstruction is a major factor in determining the severity of pancreatitis. And decompression of the biliary system reduces the morbidity and mortality. While in the conservative proponent group, they feel that the severity and prognosis is depend on the duration of, it doesn't depend upon the duration of obstruction, it happens at inception. So duration of obstruction is not a major important thing. And in around 75% of the patients, stone pass of its own. So they feel that conservative strategy is better. So there is always be a debate, what should be the timing of ERCP and which group of the patient you do an ERCP. Is all patient of acute pancreatitis? Is all patients of acute biliary pancreatitis should be subjected to ERCP or a selected group? So the queries are, is the offending stone still at the papilla or it has passed off? Does the patient has persistent biliary obstruction or cholangitis? And what should be the timing of ERCP? Less than 24 hours or early ERCP within 72 hours. So these are the important queries which is there. The concept of urgent versus early, urgent means within 24 hours and early within 24 to 72 hours. So what has changed? I always feel serving the old wine in a new bottle. Nothing has changed in the last 3 decades. Only thing what has changed in the last 3 decades is advent and the evolution of the imaging has MRCP and EUS changed the scenario, and there is an improved understanding of pathophysiology of acute pancreatitis and its classification by Atlanta. So that has changed in the last 3 decades. So if you look at the common clinical scenario, what is a patient? Because 75 to 80% of the patient has a mild pancreatitis and they are without cholangitis. So is the ERCP recommended in this? 3 important studies. Moretti et al., this is a meta-analysis of 5 randomized control trials, 700 patients. And what they have shown that early ERCP has no advantage over the conservative group in mild pancreatitis. Petrov et al., systemic review and meta-analysis, 5 randomized control trial, 717 patients. And what they have shown that early ERCP did not reduce the risk of local complication in mild acute pancreatitis. Genan, systemic review of 8 meta-analysis, 12 guidelines, except first meta-analysis, all included studies disapproved the early ERCP. So the answer is ERCP is not recommended in 80% of the patient where there is a mild pancreatitis without cholangitis. The second group is severe acute biliary pancreatitis without cholangitis. What is the literature says? False prospective multicenter study prematurely terminated. Why? Because they have seen that overall rate of morbidity and mortality was similar, but in ERCP group has more severe complication, more respiratory failure. The mortality in acute pancreatitis was higher in the ERCP group. Mortality in the severe acute pancreatitis was higher in the ERCP group. So what is the message? That in patient of severe acute biliary pancreatitis, without cholangitis. This is a meta-analysis, 450 patient, 213 ERCP, 220 conservative, and early ERCP in severe acute biliary pancreatitis without acute cholangitis, no reduction in mortality, no reduction in complication. In fact, the respiratory failure was high. This is a landmark APEX study published in Lancet 2020. And what they have seen that urgent ERCP with sphincterotomy versus conservative, there is no change in the mortality and morbidity in a patient without cholangitis. Even patient who has a cholestasis, no cholangitis, but jaundice is there. Again, there was no significant difference without cholestasis or with cholestasis. So the jury is out in severe acute biliary pancreatitis without cholangitis. ERCP is not recommended. So any patient of acute biliary pancreatitis, even if he is jaundice, that doesn't mean that he warrant an ERCP. This is the group, severe acute biliary pancreatitis with cholangitis. Important, 2 studies, Neoptolemus, ERCP is useful. Centrovert et al., what he has shown that in ERCP group, there are less complication, 25 versus 54 in the conservative group. Less patient with more than 30% necrosis in an early ERCP group, and mortality was lower after the ERCP, 6 versus 15% in the conservative group. This is a Cochrane meta-analysis of 5 randomized control trial, and what they have shown that early ERCP patient with cholangitis reduces the mortality, reduce local and the systemic complication as defined by Atlanta. So this is an ESG guidelines, and what they have shown that except cholangitis, doing ERCP is not recommended. And possible explanation is doing an ERCP is not going to improve the outcome. In fact, it is going to create more problem. So the jury means patient of acute biliary pancreatitis with cholangitis, ERCP to be done on an emergency basis. It is better to do within 24 hours. Because if you delay, there's a lot of duodenal edema and it is difficult to do the ERCP. And sometimes you worsen the pancreatic necrosis by repeatedly cannulating the pancreatic duct. But what is the true challenge? How to differentiate? Is this feature is because of acute severe pancreatitis or it is because of the cholangitis? Because in acute severe pancreatitis, patient will have abdominal pain, patient might have a SIRS syndrome because in the form of fever, mental confusion, hypotension, and the jaundice. And same thing happen in a patient of cholangitis also. So can we differentiate both these conditions? Ultrasound has a poor sensitivity. You may find with the bilated duct. Now, with an advent of MRCP and US, you don't require these patients to do an early ERCP if there is no cholangitis. So how can you differentiate? MRCP to be done or EUS? If you ask me which is the better modality, in my opinion, EUS is the best. Why? Because stone which is less than 6 millimeter, MRCP sensitivity goes down to 60%. Stone impacted at the ampulla, MRCP has a poor resolution at the ampullary orifice. You see the MRCP images, ampulla is not clearly visible. In EUS, smaller stone, sensitivity and specificity is up to the tune of 95%. It is better for the small stone. Another advantage is, in the same setting, when the patient is sedated for EUS, if you find patient has a stone, you can, in the same setting, by changing the scope, you can do the ERCP. MRCP also observer dependent, because people talk about it is an operator dependent, but it will depend upon the image quality of the scanner also for the MRCP. So EUS versus MRCP, I think EUS is superior. It gives a real-time dynamic imaging, can be combined with the ERCP in the same session and same anesthesia. EUS access, although is not available universal, where the EUS facilities are not available, I request MRCP is important rather than doing the direct ERCP. So this is my last slide about the acute biliary pancreatitis. As I said, 80% of the patient has a mild pancreatitis, if there is an obstruction, if there is acute cholangitis, it is better to do the ERCP, do the sphincterotomy. If severe biliary pancreatitis, if there is no obstruction, do a conservative treatment. If there is a suspected obstruction in the form of dilated bile duct or LFT is abnormal, do an EUS or MRCP. If there is a presence of obstruction or there is no obstruction, if there is no obstruction, treat conservatively. If there is an obstruction, if there is a presence of the CBD stone, and if there is a cholangitis, do an urgent ERCP. Mere presence of a CBD stone in a patient of acute severe pancreatitis without cholangitis, don't rush for the ERCP. Otherwise, you may end up more doing the harm to the patient in comparison to benefit. So, ladies and gentlemen, to summarize, ERCP in acute biliary pancreatitis with cholangitis, ERCP to be performed. Biliary obstruction should be confirmed before ERCP. EUS and MRCP are comparable for diagnosis of biliary obstruction. Presence of the CBD stone is not an indication of ERCP in acute severe pancreatitis. Aggressive hydration. What is more important is aggressive hydration must be done. Even if patient has a cholangitis, don't just jump on the ERCP. Hydrate these patients because first 48 hours are crucial in these group of the patient. If even on the ERCP table, your hydration should continue because many of the time from ward to endoscopy room, you lose around 3 to 4 hours and patient require hydration at that time. So pain management and hydration is important even while doing the emergency ERCP. So Dr. Baiju, should I start with the third presentation?
You can go ahead. Go ahead. We can have the question answer last.
Okay. So this, I think, I'm not sure this topic has been covered in the past or not, but this is very close to, actually all these pancreatic endotherapy is very close to my heart. And I have a publication also on the pancreatic fluid collection. So how to approach these patients and how to manage this is very important. So if you look at the timeline curve, in 1980, surgery in all patients of acute necrotizing pancreatitis. And there's a significant morbidity and mortality. In 1990, a decade before, people started thinking that non-operative management is better. And in 1997, the concept came, the late necrosectomy is better than early surgery. And from 2000 to 2010, I think the Dutch Penter trial or Dr. Pramod from All India Institute of Science, it has changed the significant and there's a paradigm shift. 35% of the patient of infected necrosis or a minimally approach by the Penter trial, a step-up approach is better rather than doing an early intervention. And I think 2018 and 19 tension in the MESA trial has shown that the endoscopic transluminal approach is equivalent or better in comparison to surgery. So the dictum is to delay or only drain if required, then do the debridement rather than doing the early intervention. So if you look at these photographs, before Atlanta, it was very difficult to know that what are you dealing. People describe as a acute pseudocyst, somebody described as a chronic pseudocyst in a patient of chronic pancreatitis, or patient described as a pancreatic abscess. And you all see such kind of images in your day-to-day life. But I think the Atlanta classification had made our job very easy. What they have defined is around 80 to 85% of the patient has a mild pancreatitis and less than 4 weeks, acute fluid collection is called as acute peripancreatic fluid collection, where there is no necrosis. In 15% of the patient, where there is a necrosis, that is called as acute necrotic fluid collection when they are less than 4 weeks. And when it happens more than 4 weeks, acute fluid collection convert to the pseudocyst. Around 75% of the acute fluid collection resolve of its own. but 10 to 15% convert to the pseudocyst. And pseudocyst may be sterile or they may be infected. Same with the acute necrotic fluid collection. A significant chunk may be disappear or improve of its own, but after 4 weeks, they form a walled-off necrosis that is called as walled-off pancreatic necrosis. And again, it may be intrapancreatic, it may be extrapancreatic, and it may be sterile or it is infected. So I think Atlanta classification has made our job very easy. Now the question comes, why it is important to differentiate that are you dealing with the pseudocyst or are you dealing with the walled-off pancreatic necrosis? So first of all, I would like to say a history is very important. If patient has a mild pancreatitis, he remain in the hospital for 2 to 3 days or 5 days, chances of a pseudocyst is very high. Clinically, I am talking. And if patient has a difficult course in the hospital, he spent time in the hospital, in ICU, followed by the high dependency unit to the ward, the possibility of a necrotizing pancreatitis is high. And those collection may be walled-off pancreatic necrosis. And why it is important to differentiate? Because the treatment success is better with the pseudocyst. Adverse events are less while managing the pseudocyst. The number of intervention required is less and the length in the hospital is required less. So patient who has a VON, the success is less, adverse events are more, number of intervention requires are more. So it is very important whenever a pancreatic fluid collection comes to you, try to differentiate, are you dealing with the pseudocyst or are you dealing with the walled-off pancreatic necrosis? And how can you differentiate? A history is very important. Otherwise, MRI is superior to the CT scan or endoscopic ultrasound, even a transabdominal ultrasound also differentiate, are you dealing with the pseudocyst or are you dealing with the walled-off pancreatic necrosis? Treatment option, it is very important when you are dealing with the pancreatic fluid collection. It is a multidisciplinary, it is a critical care in a patient of severe pancreatitis, gastroenterologist, interventional radiologist, as well as surgeons. And I always feel it is important that in first week, ICU and the gastroenterologists are important. And in the second, third, and the fourth week, I think all 4 teams of the doctors are very important. I will discuss about the management of pancreatic fluid collection on the basis of case. So this is the case number 1. A 56-year-old female who presented with the acute pancreatitis. And CT scan was done on the day 5. And CT scan shows no necrosis, there was peripancreatic fluid collection. Patient pain subsided, there was no fever. An ultrasound shows gallbladder stone and CBD was normal. This was a CT scan. You can look at here. There is a small amount of fluid collection, peripancreatic, near the spleen and near the head. Entire pancreas appears to be hyperperfused. So no evidence of pancreatic necrosis. And you see the patient has a acute peripancreatic fluid collection after an episode of mild pancreatitis. So what is the diagnosis? Acute interstitial or mild pancreatitis with acute fluid collection. There was no necrosis and there was no sepsis. So what should be the jury in these patients? The management should be expected treatment, patient improve. You don't require to drain these patients. So 85% of the pancreatitis are mild pancreatitis. And majority of these time, even if the patient has a fever, you wait for a few days because it is because of the systemic inflammatory response syndrome. These patients improve of its own. No need to try to drain these fluids. Case 2, a young man who presented with acute pancreatitis, admitted in the 2nd week of illness. Look at here, 2nd week. Initially had fever, responded to antibiotics. The problem was abdominal discomfort, early satiety and vomiting. So he had fever, he was given antibiotic. Now he admitted 2nd week with the abdominal discomfort, early satiety and the vomiting. And this is the CT scan. That shows there is an acute necrotic fluid collection. You can see the pancreatic duct in the head is not visual. A pancreatic parenchyma in the head is not properly visualized. There is a necrotic fluid collection in the lesser sac, and there is a peripancreatic and perisplenic fluid is also there. So this is a case of acute necrotizing pancreatitis with acute necrotic fluid collection. And what should be the treatment? Again, no intervention required, because patient complain of an early satiety, there's abdominal heaviness, he's not running the fever. There's a sterile necrosis. So patient of acute necrotizing pancreatitis who has a sterile necrosis, they only require conservative treatment. They don't require a drainage of these collection. So what the guideline says, the sterile fluid collection should be treated conservatively. Drainage is only done if they are symptomatic. Case number 3, 45-year-old female. CT scan shows 50% necrosis. Early organ failure, ICU treatment, patient improved. He came back with a fever second week of illness. Count was 19,000. So the diagnosis was possibly because patient improved again back with the fever, there's a possibility of infected pancreatic necrosis. Patient required IV antibiotic, ICU treatment. His fever was continuing. CT scan shows a large collection. Antibiotic was changed. People sometimes do a percutaneous aspiration to look for the infection you don't require. What is the best way to know the pancreatic infection? If there's an air, or even if there is a no air, but on the clinical ground, patient is running high-grade fever in the week 3, who was stable earlier, have a leukocytosis, then possibility of infected fluid collection is there. So this is a fluid collection, and you can see now what should be the choice. As a surgeon, would you like to do a surgery, or you do a catheter drainage? So in case 3, if you look at the data from the All India Institute of Medical Science, 104 patients of infected pancreatic necrosis, what they have done, surgery versus conservative treatment. And what they have shown that the mortality was higher in the surgical group. So conservative treatment is better, less morbidity and less mortality, and success rate is very high. So this patient underwent PCD, culture shows Acinetobacter, patient improved and discharged in 6 weeks. So infected pancreatic necrosis, the question comes, will you treat conservatively or will you treat by necrosectomy? I'm not saying after 4 weeks when the wall is formed, then yes, you take a decision about surgery versus endoscopic treatment. But before the wall is formed, it is better to do a conservative treatment with antibiotic. And this is a systemic review again from All India Institute of Science, from Dr. Molly or Dr. Pramod Garg. And I think my moderator, Dr. Deepak Gunjan, was also a part of this study. It's a systemic review and meta-analysis of 8 studies, 324 patients, and what they have shown that the conservative treatment plus minus PCD was successful in 64 patients. 70% of the patient on catheter drainage, 26% required necrosectomy, and mortality was only 12%. So, infected pancreatic necrosis, 2 to 3 weeks, try to treat with an antibiotics. If patient is not responding, do a PCD drainage. And if patient running with the fever still has an ongoing infection, do the minimally invasive necrosectomy. That is better, is like a step-up approach. Case number 4, which is important, 36-year-old male presented with acute pancreatitis 12 weeks after the illness, large pseudocyst. CT scan shows large pseudocyst. Now, again, I said it is important. CT scan, sometimes it is difficult to know, are you dealing with a pseudocyst? Are you dealing with the wall of necrosis? Because if you look at the CT scan, there's no pancreatic parenchyma visible, possibility of a wall of necrosis is there. But when you do an MRI, a clear fluid without any solid debris, so you are dealing with the pseudocyst. And if patient is symptomatic, you treat this pseudocyst. And I think there is no debate. I think endoscopic treatment is the treatment of choice. You don't require surgery. And in endoscopy, EUS is better. And in my opinion, plastic stent is more than sufficient. You don't require for the treatment of pseudocyst. So the question comes, this is important. When will you intervene? A pseudocyst one, which is visible on imaging? No. All one or pseudocysts don't require treatment. You only treat if there is infection, or patient is a persistent symptoms. in the form of luminal or biliary obstruction, or patient has a failure to thrive. And it is always better, later is better, let the wall to be formed. And nowadays, 3 weeks also, if the wall is formed and the patient is symptomatic, you can treat endoscopically. So this is an example. I know that as an endosonologist, I'm showing with the help of ERCP. So first of all, I suggest my friends, even if the luminal bulge is there, the main reason of showing this, I was also doing 10 years before ERCP guided pancreatic fluid collection drainage. Even if the luminal bulge is there, risk of complication in the form of perforation, in the form of bleeding is there. So avoid ERCP guided pancreatic fluid drainage, even if you find there's a bulge is present. Why? Because many of the time there is an intervening vessel between the wall as well as into the cyst, or there is a possibility that you may land up into a perforation. And the second video you see here, there is a large collection. This is the metal stent we are doing. So my opinion is, my feeling is, endoscopically you should avoid, and in the pseudocyst, I think the metal stent is costly. It is better to use the plastic stent. I think single double pigtail plastic stent is sufficient for drainage of the pseudocyst. I have shown the video for two purposes. One is to show the technique, and second is to tell what is the best way. Plastic stents are better, single stent is better. This is my take home. And do with an EUS guided, not with the endoscope, with the side wing endoscope. Look at the literature. I think the success rate is up to the tune of 95 to 100%. So I think pseudocyst, jury is out, surgical colleagues are not required, endoscopic ultrasound guided drainage is the standard of care. Now, this is a study from Vardla Raju. When you compare pseudocyst versus surgery, what they have shown that the quality of life is better in the endoscopic group. Cost-wise, endoscopy is cheaper. Treatment success and the technical success is equal in endoscopy and surgery, but median loss of days as well as cost and the quality of life is better in endoscopic group. World of pancreatic necrosis is a different ball game, and it is important. I would like to tell my colleagues to hear nicely, and Deepak, if he's around, because he's not feeling well, his remarks are also very important. So simple drainage is excellent for the pseudocyst, but suboptimal for the world of pancreatic necrosis, because majority of these patients require either a nasocystic catheter irrigation or a multiple transluminal gateway pathway or a direct endoscopic necrosectomy, or you require a metal stent in spite of plastic stent, or you may require a dual modality of drainage. And nowadays, step-up approach is better. So what is the current strategy? Step-up approach. And what is the rationale for this? A minimally invasive source control, either by a percutaneous route or endoscopically, depend upon the expertise available in your place and depending upon the location of the fluid. You do a drainage first. If patient is still symptomatic, if patient is still infected, then do the necrosectomy. In around 40 to 45% of the patient, simple drainage of the vault of pancreatic necrosis is sufficient to control the infection. Only rest of the people may require the necrosectomy. What are the factors should be considered before draining? Should we drain or not? As I said, if the patient is asymptomatic, you don't require to drain. What are you draining? Are you draining the pseudocyst or are you draining the vault of necrosis? Are you dealing with the sterile or the infected pseudocyst? You look at underlying pathology. Are you dealing with the acute pancreatitis or a chronic pancreatitis? Is it a patient is stable or not? And what is the local expertise available? If you have a local expertise of percutaneous drainage, I still suggest do a percutaneous drainage rather than venturing into the endoscopic drainage. And you should have a backup plan, that you should have a facilities of a surgeon or you should have a facilities of a interventional radiologist, because these patients, even during endoscopy, even in the subsequent days, a subgroup of the patient may require a associated percutaneous or surgical intervention. So backup support in the form of surgery or the interventional radiology is mandatory. Who is the ideal patient for endoscopy? A von or a pseudocyst which is centrally located and periluminal, a perigastric, so is situated in the lesser sac, and who should be hemodynamically unstable. If patient is unstable, it is better to do a percutaneous rather than doing endoscopically because the patient may have more complications. Before doing an endoscopic drainage, it is important to do a CT or MRI to look for the amount of debris and look for the pseudoaneurysm. Always has a backup of surgery or intervention radiology. Adequate expertise is important. Counsel the patient about other treatment option, stop PPI, start antibiotic, check for coagulopathy, and do all procedure under CO2, avoid using the air. So endoscopic necrosectomy, I think, is very simple. Those who are doing it is going to take 10 minutes. This is the metal stand we are placing. This is the large collection. And it's going to take 5 to 10 minutes. So in around 40% of the patient, the simple drainage is sufficient. You don't require to do the necrosectomy. In my practice, I don't dilate. This is a video where I'm dilating, but generally I don't dilate because these stents expand within 6 to 8 hours. You don't require to dilate. You just wait for it. But yes, if you are planning for direct endoscopy, if the direct necrosectomy, then yes, you have to dilate, increase the size of the stoma, and then you take your upper GI scope in and do the necrosectomies. Now, what is the literature says? If you look at the Mises trial, what they shows that when they compare the endoscopy versus surgery, equal number of patients, and what they have said that primary composite endpoint in the form of complication was less in endoscopic group in comparison to surgery, and enteropancreatic cutaneous fistula was not there in endoscopic group, while they are seen in around 9 patients, that is 28% of the patient of surgical group. Another important trial, tension trial, randomized control trial of 98 patients, suspected infected pancreatic necrosis. Here they have used the plastic stent, if I'm not wrong, and they use the endoscopic step-up approach versus surgical step-up approach, 25 Dutch hospital. And what they have shown that there was no difference in the primary outcome in the form of major complication and death. But there was a 19% cost reduction. There was less new onset of cardiovascular failure. Pancreatic fistula was less, and total hospitalization days are less in endoscopic group. Now, as I said, 40% of the patients can be very well managed with the drainage alone. You don't require to go for the necrosectomy. So these are the 2 important articles. One was from India, from PGI Chandigarh. Second is published in NEJM. And what they have shown that if the necrotic debris is less than 10%, I think you just drain it and majority of these patients become okay. If patient is a 10 to 40% of these necrosis, then these patients may require necrosectomies. And if patient has more than 40, you counsel the patient that he's going to require necrosectomies. So this is a studies, 88 one, randomized between the surgery and the step-up approach, and what they have shown that 35% only require drainage. The rest of these patients may require necrosectomies. So when is the necrosectomy indicated? On index intervention, if 40% necrosis is there, or if there's a poor drainage, or patient developed the new onset of symptoms in the form of fever, or patient has a persistent non-resolving symptoms, then you should go for the endoscopic necrosectomy. So when is the endoscopic necrosectomy indicated? No response to percutaneous drainage, persistent sepsis, worsening of organ failure, or patient has a multi-drug resistance. In these cases, you should do the necrosectomies. And necrosectomies can be done endoscopically or by the ward technique, depending which method you have used. So it is better, so to summarize this, it is better to do the endoscopic or surgical intervention from week 3 to week 5. If patient has a suspected pancreatic necrosis, first give IV antibiotic and supportive care. If there is no improvement for 3 to 7 days, then you repeat the CT scan. And if you see a partially or a fully encapsulated collection, do an endoscopic drainage. And if you see a multiple fluid collection or collection which is away from the lesser sac, which is not periluminally, you do a percutaneous catheter drainage. In endoscopic catheter drainage, if patient become afebrile, no required to do the endoscopic necrosectomy. But if patient has a persistent of symptoms, if new onset of fever, then do the endoscopic necrosectomy. And in the percutaneous necrosectomy, either you can do the percutaneous endoscopic necrosectomy or you can do the ward, depending upon the location of the infection. A brief about which stent, because the literature is diversified. Many people talk about the LEMS. The few studies shows the plastic stent also has a similar results. So this is a article which was published in Clinical Endoscopy, and what they have shown that the large caliber metal stent appears to decrease both need for repeated necrosectomies and risk of intervention related bleed. Another meta-analysis and systemic review, GI endoscopy, 41 studies, 2,000 patients. And what they have shown that Vaughan resolution is more likely with the metal stent comparison to plastic stent. Metal stent group has a fewer intervention. Metal stent were associated with the lower bleeding and trend towards lower perforation and the stent occlusion. So to conclude that metal stents are better. But this is the study has changed the concept from the Bank Group GUT 2018, and what they have shown that the additional drainage is less in the metal group, but the stent-related complications was more in the metal stent group in comparison to plastic, and they were the proponent of the plastic stent. But recently the concept came, if you're putting a metal stent, try to remove within 3 weeks. Then the stent-related complications are less, and if required, you can change metal stent to the plastic stent. So that is important. And which stent? Metal stent, if one has a significant debris. Plastic stent in the cases of pseudocyst or one with the minimal debris. Reintervention should be based on the symptoms. Not all drainage of one require a reintervention in the form of necrosectomies. It should be depending upon the clinical situation. Remove the LEMS early within 3 to 4 weeks, so LEMS related complication will be less. A few words when you come across with such kind of fluid collection, that is patient has a paragolic cutter extension along with the lesser sac. So I think depending upon the local expertise, you should do it. You can do endoscopic treatment of the lesser sac, and you can do the percutaneous drainage of the paragolic cutter extension. And if the patient is symptomatic, if you look at this, this is from All India Institute of Medical Sciences, from Dr. Pramod Garg group, and they did the pancreatic endoscopic, percutaneous endoscopic necrosectomy. You dilate, or you can put the metal stent from the percutaneous route, go with the scope, with the nephroscope or with the pediatric endoscope, and remove the necrotic debris. This can be done bedside, even in the ICU patients. So you can avoid the surgical intervention in these patients. So ladies and gentlemen, to conclude, acute fluid collection, no necrosis, they resolve of its own. They don't require any endotherapy or any kind of intervention. Acute necrotic fluid collection, they also resolve. If they are symptomatic only, then do a percutaneous drainage. Don't fiddle acute necrotic fluid collection with a surgery or with the endoscopic means. When to drain? When the patient is symptomatic. It is always better that you delay as much as possible, not on the cost of patient health. Pseudocyst, plastic stent are better, Vaughan LEMS are better, and it should be done in a place where the multidisciplinary setting is there. Thank you. Dr. Baiju, do we have time for the last talk, or we should?
Yeah, we have time because for the completion sake, we'll have to cover the chronic pancreatitis also.
Okay, so I will try to wrap up in 10 to 12 minutes. And pancreatic endotherapy in chronic pancreatitis, I think this is very important topic. And What is the role of endotherapy or endoscopic treatment? It should only be done if the patient is symptomatic in the form of pain. If a patient of chronic pancreatitis, if you find a dilated duct with the multiple stones, but if he has no stones, you don't require endotherapy. And how can you manage these patients? You can manage with the medical treatment, which I'm not going to talk, but yes, I will be happy to answer if there is any question. You do an endoscopic treatment or you do a surgical treatment, and this is a big debate, which group of the patient should directly subjected to a surgery or which patient should be taken up for endoscopy. I think there is a reasonably well demarcation is there. If you are using the judiciously your knowledge, then you can plan. It is better to subject this patient for surgery rather than endotherapy venturing. Or if a patient who comes, you feel that endoscopic treatment can cure him, can treat him well in a less number of time with a less number of intervention, it is better to subject this patient for endoscopic treatment. I think that is very important for endoscopist or a gastroenterologist, even for the surgeon to understand. We should select carefully patient who is good for endoscopy and which patient is good for surgery. I think that decision should come from the doctor who is treating the patient or the patient who visited a doctor. In chronic pancreatitis, a lot of complication can happen in the form of stones, stricture, ductal leak, CBD stricture, pseudocyst, pancreatic malignancy, and the duodenal narrowing. I will remain my talk to the strictures in the stones. Will be happy to answer rest of the complication because it's going to take a long time to discuss. So it is a challenging situation. First of all, it is important to understand. And what we find is mainly I'm going to talk about the pancreatic endotherapy of the pancreatic strictures and pancreatic stone. The rest, the CBD stricture, pseudocyst, those things I'm not going to cover now. Pancreatic duct stricture. It is seen in around 20 to 50% of the patient of chronic pancreatitis. Who is the ideal candidate for endoscopy and who is the ideal candidate for surgery? What I do in my practice, what I understood from the literature, if patient has a stricture in the head of the pancreas or the proximal body, and the distal duct is dilated as shown in this, and you exclude the malignancy, it is better to do an endoscopic treatment. But if patient has a multiple strictures, or patient, the complete pancreatic duct is studded with the stone, it is better to subject that patient for the surgical intervention. So I think by this slide also, we are very clear. A stone disease in the head of the pancreas with the distal dilatation, you can try endotherapy. If the multiple stricture or the multiple stones are there in the entire pancreatic duct, it is better to subject the patient for the surgery. So 3 kinds of the endoscopic stenting is possible. You put a single plastic stent, you put a multiple plastic stent, or put a fully covered stent. So what the literature says. Important trials, single plastic stent gave pain relief in around 80 to 94% of these individuals. On demand versus prophylactic stenting every 3 months for 1 year is important. But it has shown that recurrence is seen within around 40% of the patient within 2 years. So what the ESG say? If you use a thinner stent, less than 8.5 French, these patients admitted more frequently with the hospitalization because of the blockage of the stent. So what the ESG recommend that stent exchange plan within 1 year, even if the patient is asymptomatic. You start doing with the 7 French, 8.5 French, and the 10 French, depending upon the ductal diameter, depending upon the stricture, depending upon the ease of putting the stent. But yes, presumptively you change within 2 to 3 months. Once you reach up to a diameter of 10 millimeter, then try to change in 6 to 8 months. Don't try to keep more than 1 year. Otherwise, you may come across with a complication related to the long-term pancreatic duct occlusion. And single stent, if you look at the pain relief, is seen in roughly around 65% to 94% of these individuals. So placement of a single pancreatic stent achieve MPD stricture resolution nearly in 60% of the cases, and the pain relief from 63 to 94% of these cases. Then Costa Magna has proposed a concept. As he has proposed the concept of the biliary stricture, he gave a concept of multiple stent of the pancreatic duct stricture. He put a multiple stent for 6 months, and what he has seen that the resolution of the stricture was seen in around 95% of these cases, and 84% of the cases are pain-free for 3 years. This is the slide has been taken from the Costa Magna et al. From his lecture, and you see that he has put the multiple plastic stent across the stricture depending upon the ease of putting the stent. So multiple pancreatic stent protocol, you dilate the stricture up to 6 to 8 millimeter hurricane balloon. It will be dependent upon the proximal dilatation of the pancreatic duct. And once you have dilate, you put a multiple plastic stent as much as possible. The small trick is, if you have a single pigtail stent, try to place the first single pigtail stent and then try to use the straight stent. Otherwise, sometime it happens, the stricture is tight. While introducing the second stent, there is a possibility that the first stent which you have placed migrate in. Or you leave the first stent a little bit more outer, because when you place inside, there is a possibility that along with that stent, the previous stent also go inside. You remove the plastic stent within 6 months to 1 year. And how should you know that the stricture has a resolution? If there is an easy passage of the 10 to 12 millimeter of the Fogarty balloon, that indicates that the structure has resolved. Or if there is a drainage of the dye seen within 1 to 2 minutes, that indicates that your stricture has resolved, and you give the patient stent-free trial. Now the question comes, which is very important and very oftenly asked by the surgical colleague. Is the pancreatic stenting needed lifelong? Outcome after the stent removal in 100 patients of the chronic pancreatitis. This was published in Endoscopy 2005. What they have done the median duration of stenting was 23 months, and median follow-up was 27 months after removal of the stent. And what they have shown that 30% require restenting, 70% of the patients, they were pain-free for 27 months. Now, what is the role of covered stent? Because there's a lot of noise about the fully covered metal stent, but what the literature shows, there's no difference between the multiple plastic stent versus the fully covered metal stent in the chronic pancreatitis, and 6 months with the fully covered SAMs did not lead to an expected degree of pain reduction, migration, and the side effects were common. So what the guideline says that small diameter of the fully covered SAMs make it easier to place, because when you put a multiple plastic stent across the stricture, it is difficult to place. But the major limitation of the fully covered stent is there is a high risk of migration. And there is a problem that these stents produce a stricture in the pancreatic duct because of the constant irritation. So it is very important, use judiciously the fully covered stent. I think better to use the multiple plastic stent rather than fully covered metal stent. This is the bumpy stent with the anti-migratory properties, has been launched and shows a good efficacy. Now, regarding the pancreatic duct stone. So, as I said, choosing the right patient for endoscopy is mandatory. If patient has a ductal disease in the head or head and the proximal body, you can try endoscopically. But if patient has in the head, body, and the tail pancreas, it is better not to do the endotherapy. If patient has a ductal disease, required treatment, it is better to subject these patients to the surgery. I think there's no ambiguity. Trying endotherapy multiple times and later subjecting for the surgery, it is going to increase the cost of treatment. So I think selecting a patient right for endoscopy is also important. So pancreatic duct stone is in India is more seen in the tropical pancreatitis and hereditary pancreatitis. They are larger in size in comparison to the rest of the chronic pancreatitis, and they are full in entire length. If patient has a stone of less than 5 millimeter, it is better to amenable with the endoscopic extraction. If they are more than 5 millimeter, it is better to do the ESWL prior to doing the endotherapy. In alcoholic pancreatitis, strictures are also very common. The most important problem arises if the stones are not radio opaque, then the ESWL is not possible. In radiolucent stone, it is difficult. What you do in this situation is put the nasopancreatic drain and take a pancreatogram at the time of ESWL. You can demonstrate the stone and you can do the ESWL. As I said in the previous slide, what I do in my practice is I dilate the pancreatic orifice after the sphincterotomy with the 1 centimeter hurricane balloon, and up to 6 to 7 millimeter pancreatic stone can very well remove with this. So I think this is a good technique. That is like a balloon sphincteroplasty, what we were doing for the large CBD stone. We were dilating with a CRE balloon up to 15 millimeter or 18 millimeter. Here we dilate up to 1 centimeter, and the stone of 5 to 6 or 7 millimeter can be very well removed. Option for the challenging stones, you have a mechanical lithotripsy, but I think it is not commonly done. And I suggest even a Dormia basket is not very good for removing the pancreatic stones. Sometimes it got entangled. ESWL is the standard of care when the patient is fit for endoscopy. Otherwise, it is better to deal with the surgery. I think role of pancreatoscopy is very minimal. I'm not going to discuss in detail because pancreatoscopy is limited to for the small subgroup of the patient where the pancreatic duct is dilated and the stone is in the head of the proximal body. Otherwise, taking the pancreatoscopy in and doing the lithotripsy is not a fascinating idea. Yes, few case report and the case series are available, but in my practice, I generally don't use the pancreatoscopy. I prefer to do the ESWL or opt for the surgical intervention. I think ESWL is the most important standard of the care, and the factor predicting the success of ESWL is depend upon the stone size and the density, presence of a pancreatic duct stricture, what is the duration of the disease, and is the patient is using the narcotics or not. Technical factor, operator experience is very important. Type of lithotripter machine is also very important. Patient, it should be done in epidural anesthesia because it produces a pain. You may use the secretine. So these are the few images. Look at the large stone pre-ESWL, and once you do the ESWL, it pulverizes the stone into the small particles, and you can do the ERCP. So the one important thing is which I want to mention, many of the colleagues who are doing the ERCP, ESWL consistently provides stone fragmentation in more than 90% of the patient. And if the stones are pulverized, majority of these time you don't require to do the ERCP. Stone come of its own. You don't subject these patients for ERCP and stenting. If there's no stricture in the MRCP, there is a stone only, do a good ESWL in around 70 to 80% of the time. Even you don't require a pancreatic sphincterotomy, you don't require an ERCP to remove the stones. Spontaneous elimination of the stone fragment after the ESWL is seen in around 80% of these patients. So ESW alone or with the ERCP, this is a study of 55 patients randomized to ESWL alone versus EUSWL versus endoscopy. And what they have shown that in both the group, the pain relief was similar. So there is no need to do an additional ERCP to increase the cost of treatment. I think if the stone is completely pulverized, more than 80% of the time, stone come off its own. So this is one of the largest study which was published in Pancreatology 2009 from India, from Dr. Nageshwar Reddy and Dr. Manu Tandon group, more than 5,000 patients. And what they have shown that ESWL with an endotherapy, complete clearance was seen in 72% of cases, partial clearance in 17, and no fragmentation in 10, short-term relief in 74, and 3 sessions or less required in 68% of these patients. So this is one of the largest studies, more than 5,000 patients. This is with the more than 1,000 patients, and the long-term follow-up they have done for 3 years and the 5 years, and what they have shown that 60% of these patients have a long-term pain relief. So what the guideline says, uncomplicated, painful chronic pancreatitis and radiopaque stone more than 5 millimeter obstructing the main pancreatic duct. ESG recommend ESWL as a first step, immediately followed by an endoscopy. But now the recent paper says you just do an ESWL. ESWL alone should be preferred over ESWL combined with the ERCP. Endoscopic attempt to extract radiopaque stone without prior fragmentation should be only be considered, meaning that you directly subject them for the ERCP rather than ESWL if the stones are less than 5 millimeter, low in number, located in the head, and if you find it is difficult to remove, it is better to do the balloon sphincteroplasty up to 1 centimeter, and you can remove the stone up to 5 millimeter. Intraductal lithotripsy should be attempted only after failure of ESWL. In day-to-day practice, I don't try the pancreatic lithotripsy. But pancreatoscopy is available. Case reports in the case series are there. You can see the stone in the neck of the pancreas. You take your EHL probe, blast, and you can fragment them into the small pieces. Today, in my opinion, I may be wrong. People may disagree. It is more of a fancy thing rather than using in day-to-day practice, because pancreatic duct is angulated. It is not dilated. Taking the accessories of 10 French, flushing with the water increases the risk of pancreatitis. This is my take home for this device. So what to do and when? Small stones, ERCP and stone extraction, you can do the balloon sphincteroplasty. If the stones are larger, do the ESWL without ERCP. Pancreatic lithotripsy should be reserved in the small subset of patient. Stricture in the stone, do the ESWL, dilate the stricture, and then do the ERCP and remove the stone. Only stricture, you do a multiple plastic stent. If patient has a full length of the stones are studied in the pancreatic duct, or patient has a multiple stricture, subject them for surgery rather than doing the endotherapy. What are the factors predicting the successful endotherapy? I said location of obstruction limited to head, short disease duration, low frequency of pain, complete MPD clearance, absence of MPD stricture, treat it in the head and treat it early. That should be the rectum. So ladies and gentlemen, to summarize, pancreatic endotherapy is the mainstay of treatment for chronic pancreatitis. Single or multiple plastic stents are successful. Fully covered stents are still in evolution. ESWL, I think, is useful for the large stone. Ideal selection of patient is the most important. You should remember, surgery is also a very good option in painful chronic pancreatitis. All patients should not be taken for endotherapy. It is important, choose the right patient for the right indication. By that, I will complete my talk. And those who are interested, we are doing an interventional pancreatobiliary congress on the May 27th and 28th. Those who are interested, they are most welcome. They can communicate through Dr. Baiju, or we are going soon to launch the website. You can directly register. Thank you for the patience hearing. I will be happy to answer if there's any question.
Congratulations and brilliant talk as expected, Dr. Rajesh Puri. As a surgeon, actually, I learned a lot by this talk. I am doing some endotherapies as well. Though I am a surgeon, I do ERCPs also. So I got a lot of new points in this talk. If Deepak Gunjan is okay with his voice, we can just say 2 words about this talk, and then I will take over for moderation.
Sir, this is brilliant talk. I think you can take over.
Okay. Thank you, Dr. Deepak. And we entertain one-to-one interaction in all the webinars. So I request anybody having a question, please raise your hand so that I can unmute you. You can ask the questions directly. By the time I'll be taking the questions from the chat box, there are a lot of basic questions. Before that, let me ask you, Dr. Rajesh Puri, regarding the basic this thing, cannulation. So you were talking about blunt current and pure cut. What is your preference of pancreatic duct cutting?
Yeah, I think it's a very good question, sir. So in a chronic pancreatitis, I use the pure current or blended current. But when I'm dealing with the acute pancreatitis, if I require to do it, then I always use the pure current rather than using the blended current, because coagulation produces more edema. So
yeah, that will produce more damage to pancreas. And you were talking about NBA in cannulation. The role of NBA. You just you were giving a passing comment about NBA. What was it?
So basically, it is to visualize the papilla in a better way. It gives the better visualization. In the normal white light endoscopy, sometimes it is difficult because of the edema or so. So when you apply the NBI, you may be able to see a small area where there's a scarring or fibrosis. That is the area, as I shown in my endoscopic view also. But in day-to-day practice, not all patients are benefited with an NBI also.
And about cutting the pancreatic duct, you said it's better to cut the pancreatic duct after stenting. Why is it so?
Especially in the minor papilla, sometimes it is difficult because you are in a difficult position, you are in the long loop, or because of the duodenal wall edema, you are not in a stable position. So first you do make sure that the direction of cut is okay. And second is your scope is in a stable position. So you have achieved the access to the pancreatic duct by putting the stent. And even you can do the sphincterotomy later also when the edema subsides. So you take that advantage that your cannulation is complete, and sometimes the boundaries are blurred, especially in the minor papilla. In a patient who has a recent acute pancreatitis, you are not very sure how much I should cut. The direction of cut is not adequate. So you achieve access by putting the stent, and the next time when you are going, you can do the needle knife over it also.
Thank you. Regarding the contrast which you used, we usually use a diluted contrast, and you are mentioning about absolute contrast. What is the preference?
Yeah, I said actually what I mean to say, in bile duct, we use 50-50 dilution. In pancreatic duct, we use 80-20 dilution. The reason is that you require a very less amount of dye to be injected, and you
20%
get
of the total volume will be contrast, right?
Yes, sir.
20% of the dilution. Means
Yeah,
the
20.
contrast will be 20%, and the rest will be dilute.
Yes, yes.
Actually, that was not clear in our this thing. And regarding a basic question about which wire will you like to use, Thermo, Acrobat, Delta?
But angle tip thermo is the best.
Okay.
Angle tip thermo is the best. Two things which I want to tell you. Angle tip thermo, number one, try to see the good fluoro. When you take a pancreatogram, you see, because the pancreatic duct has a side branches also. Sometimes when you take a straight wire, you go through the side branch and you perforate. Second is, tell your technician to make the angle like this of your wire. Then it is not going to damage. This is a U shape, and then it will follow the path of duct. It is not going to puncture the side branches. So once the angle is formed, then 99% of the time, your wire will go across the main pancreatic duct, not into the side branches. Even if there is an ANSA loop, you have seen my one of the video. In the ANSA loop, the wire was going into the side branch.
Okay.
So in that case, if you have not taken the pancreatogram, you are not very sure that the wire which is going is in the duct or in the pancreatic parenchyma or so. So take a small pancreatogram, make a loop of the wire like this, and then go. It is shown in my one of the fluoroscopic video when I show. And in that case, the risk of damage to the pancreatic parenchyma and the duct is very less.
And when you do a biliary cannulation, if the contrast has gone to the pancreatic duct by accident, what will you do?
Yeah, so 2-3 things which I want to tell you. Number one, in chronic pancreatitis, it hardly make any difference. Elderly people, not much of the problem. I'm not saying it cannot, but less in comparison to young females where the risk of pancreatitis is very high. If the contrast has gone once and it has drained while doing ERCP, we don't do anything.
Okay, we don't do
If contrast remain while doing the procedures, or we have injected multiple times, we put a stent. Third thing which I want to tell you, very important. This is a common mistake which has been done by the young colleague. You have put a multiple time fiddling of the pancreatic duct with the wire. The dye has gone. Now the wire has gone to the CBD and you have done the CBD endotherapy. But now it is difficult to go to the pancreatic duct. So if you have fiddled many times, it is better before biliary sphincterotomy, put a stent into the pancreatic duct, because later going to the pancreatic duct, sometimes it is difficult. And to engage your wire and the stent in the pancreatic duct, you fiddle more, the patient will end up into a more pancreatitis. So on table, you take your clinical decision. Young patients, you have gone 2 to 3 times. If you feel that you have injected the contrast into the pancreatic duct and your wire is in the duct, it is better to put the 5 French single pigtail stent rather than doing the complete work and then finding out the pancreatic duct.
Yeah.
And once the pancreatic stent is inside, again, important thing, remove within 7 to 10 days. Many of the time patient comes, a prophylactic stent was placed 6 months before, and when you come to you see the stent was there. So stent related changes also happen. So please tell the patient, once you have done the pancreatic stenting, while cannulating the bile duct, it is important you should call him after 5 to 10 days or 7 days and remove the pancreatic stent. Although they fall off its own, but if it doesn't fall off its own, in fluoroscopy, if they are visible, it is better to within 2 weeks you should remove.
Okay, understand. And regarding the necrosectomy, actually, you said if there is the solid component is less than 10%, you don't have to do anything. Between 10 and 30%, you have to. But that the publication was in 2014, and a lot of things has changed by 9 years of time because the newer techniques and other modalities has come. Is it holding true even in this 2023?
So the important message from this is, the most important thing is, after drainage, if patient still has signs and symptom of infection, you should do the necrostectomies. This is the final word. What has shown in the literature, those who has a less necrosis, chances of necrostectomy is less in those group of patients. Those patients who has a 40% or more than that, the chances of going for the multiple necrostectomy sessions are more. But the final line is, after drainage, if the SIRS is persisting, if the sepsis is persisting, then these patients should be subjected to necrostectomy, irrespective of amount of necrotic material inside the wound.
Understand. Dr. Kamal Baghdadi, can you please unmute? I have unmuted you. Can you please ask your question directly?
Thank you. Thank you for Mr. Speaker for this informative and valuable lecture. Really, it adds to our knowledge. Just I came late on the session. I apologize for that because I was busy. One thing I want to add, when they are doing management with the ESWL for stones, we have some problems of infection regarding these patients when we subject them to ESWL. Just I would like to have a comment from Mr. Speaker if he if he could comment on the infection. If he combines the ESWL with ERCP or ESWL alone, is there how much the risk of infection
This
in
has
his
been
patients?
covered actually.
And what was the knowledge? Pardon?
It was covered in the talk actually, or Rajesh Puri can talk once again. That.
Yeah, what I understood from your question is, when you do an ESWL, should you do ERCP or not? And second, infection. My best of knowledge, yeah, number one, if you have done the good ESWL, the stone is pulverized, you look at the fluoroscopy, and if there is no stone burden and there's no pain, you don't require to do the ERCP. That is number one. Number second, regarding the infection, where is because of the pancreatitis or infection somewhere else?
No, because I am saying regarding ESWL, it causes some tear, unnoticeable tears through tissues, especially the colonic walls. And then this can lead to transient bacteremia or septicemia. How far is that in your patients?
Yeah, this is a very good
This is why
question.
we cover them with antibiotics as prophylactic before we do this procedure. And then we do for them colonic wash.
Yeah, I understood what you are saying. It's a very good, relevant question. So what is most important thing is, that's why the role of technician or the doctor who is doing the ESWL is very important, because what you require is a targeted ESWL. The risk to the duodenal wall and the colonic wall is there if you are not doing the targeted ESWL. If patient has colonic perf, then yes, the patient will require antibiotic and the treatment. But in the day-to-day life, these patients don't require a prophylactic antibiotics. And if your technician is good, what is the most important complication is cutaneous erythema, which has happened, and patient may develop the pain. But you don't require to give the prophylactic antibiotics if the targeted ESWL is not given, it has damaged the colon, it has damaged the duodenum, then these patients may require a prophylactic antibiotic. What is your take home, Dr. Deepak? Do you do the antibiotics?
In our patients with stones, when we subject them to ESWL, our routine is that we usually do colonic preparation and we do coagulation profile and we give them antibiotics, prophylactic, pre and post. And the most important for us also is the coagulation profile. We have to do that. For patients on anticoagulant, there is separate regime, separate management.
So in the literature, as well as in my practice, we don't give antibiotics. We don't do a preparation for the colonic preparation. What we do, we keep the patient nil by mouth, because most of the procedure done under the deep sedation, propofol. And the most important thing is a right targeted. Like when you give a radiotherapy, earlier the radiotherapy was given and a lot of complications happen. But now intensity modulated radiation, which is targeted, the risk of complication are less and the success of treatment is more, and you require less radiation. Same with the ESWL. If you do a targeted ESWL in the radio-opaque stone, risk of complications are very less. But if the colonic perforation happen, these patients require ideally a surgery. I think antibiotic even alone or prophylactic antibiotic is not going to help in any of the way. This is my...
we got your point.
Yeah.
We thank you for your nice comments. But
Welcome.
still, I want one point to add is that bleeding is a risk in our patients. Yeah, and we got some patients who got bleeding in spite of good coagulation profile. But infection is a bit more in our patients. Transient bacteremia, sepsis, frank sepsis is rare.
How much shock wave your technician or doctor is giving?
This is a good question, but I cannot answer for you because shock wave is done in a third party department. It's not in our department. In a third party.
Two
in a
things which
different part.
I want to highlight. That is number one.
Hmm. Yeah.
Many people complains that stones are not fragmented because they are giving the less shock wave. And the complication
agree.
they produce if you are giving more shock wave. Shock wave defined roughly around 5,000 shock wave. If you just inquire from the doctor who is giving, if he's giving more higher shock wave, risk of bleeding and perforation may be high.
Good.
So
We need to cooperate.
5,000 shock waves are important.
We need to cooperate with the shockwave department.
Yes, sir. Yes, sir.
Thank you.
Thank you.
Thank you for
Dr. Kamal Baghdadi.
Thank
And next is Dr. Deepak Johnson from Kerala. Dr. Deepak, you are on. Your mic is on.
Sir, good evening, sir. Thank you very much for the exhaustive lecture. I have 4 questions if time permits. I will start first. Sir, what is your antibiotic protocol for pancreatic cirrhosis drainage? Single dose or you give follow-up antibiotics also after case?
Yeah, it's a very good question. So what we do in a patient of pseudocyst, we do a IV antibiotic 3rd generation cephalosporin. Although it's not written in the literature, it differs from individual to individuals. We give 3rd generation cephalosporin before procedure, and for the day 1 till the patient is in the hospital, we give IV, and then 3 to 5 days of oral antibiotics. In a patient of walled-off pancreatic necrosis, again we start with the 3rd generation cephalosporin, or if the patient has infected pancreatic necrosis, he may be on the carbapenems. But while starting the procedure, we collect the fluid for the culture sensitivity, and depending upon the sensitivity profile, we change the antibiotics.
Okay, sir. So second question is regarding ESWL. Very few centers have a dedicated pancreatic lithotripter. So why can't we use the urology ESWL machine? What are the technical barriers for using it for pancreatic ESWL?
No, we are using the urology ESWL machine. What is required is a shock wave, how much you are giving.
Okay.
If you give 5,000 shock wave, it can be given from the urology machine also.
Okay.
So important thing is, technician should be trained. What he does is around 2,000 to 3,000 shock wave eggs he is doing in the for the kidney stones. They keep on giving. Actually, I will tell you, in the beginning of my career when I was in Gangaram, for around 15 to 20 cases, I go with him. I was also a newcomer. I was not aware. He do ESWL and never be stone has broken. For 1 year, I was wondering, is this procedure is really helpful or not?
Okay.
Then when I read the literature and I find out 5,000 shocks are required, I discussed with him. He said, I'm giving 2,000 because for the kidney, we are giving 2,000. And once we started giving 5,000, our 30% of the ERCP has reduced for chronic pancreatitis. We just do the ESWL and we see under fluoroscopically stones pulverize and come off its own.
Okay, sir. So third question is, what is the endpoint of direct necrosectomy? How many sessions? Is it resolution of fever, or is it a clean, healthy, red appearing cavity? What is the endpoint?
That is a very good question, actually. Number one, I think we have discussed many times what is it should be on demand. On demand means if there's an ongoing infection, SIRS is continuing, then you do the necrosectomy. And the end point is when the patient symptoms disappear. You don't require to look for the, many of the time what happened is you may find the pink granulation tissue, but there's a separate cavity which contains pus, which is not seen endoscopically. So endoscopic appearance is not important. What is important is the symptoms. If patient sepsis has improved, that is the end point of your necrosectomy. Is that right, Dr. Gunjan?
So last question, in infected WPN, patient is already on antibiotics and continuing to have fever. So you're planning to drain the patient using a LAMPS. But it's very, very important to get the pus for culture and sensitivity. But the LAMPS device does not have a port to aspirate the pus. So how do you tackle that?
Yeah, again, is a very good question, Dr. Saab. So 2-3 things. 90% of the individual in India, I'm talking, people don't use lamps. People use the tubular stents where you puncture with the EUS needle. But yes, if you are using the lamps, once lamps open up, pus started coming out, you can take cannula in and you can aspirate it.
Okay, sir. Thank you. Thank you.
Thank you, Dr. Deepak. Dr. Rajesh Puri, you have a huge fan base from Pakistan. Dr. Sabeen Farhan, do you know him? Sabeen Farhan is a huge fan of you, and I've got many questions to ask. If Sabeen is there, he can unmute and ask questions directly.
Thank you very much for your for the wonderful talk. I did have a couple of questions. You have actually answered many of them regarding the choice of the wire. You said that the Terumo angle tip was a better one. Then I had some questions about the EHL settings. You've answered that as well. Regarding the Sohindra stent retriever, please guide about that as well. When do you use that? What are the tricks for using a Sohindra stent retrieval in a main pancreatic duct, please?
So you are talking about the migrated pancreatic stent removal? Are you talking about the migrated pancreatic stents?
Dr. Sabeen? Can you please unmute? Yeah.
Yeah. All right. So I was talking particularly when we are dealing with a stricture in the pancreatic duct. I cannot get my wire across. I'm trying to negotiate it, but I can't get it across. And I've seen some people use a Sohindra stent retriever to grill their way across. So what's the technique? What's the tip for that?
It's true. I think it's a very good question, and I will tell you, I have not covered one of my presentation in this. So the wire going across the stricture is mandatory. That's most important thing. You cannot use the Sohindra retriever blindly across the stricture to negotiate. But in the beginning, to dilate the stricture over the wire, people has the Sohindra retriever. And what is Sohindra retriever? From outside, when you rotate, it burrow inside the stricture. That's number one. What I have done, Sohindra retriever sometimes take a long time. What I do when there's a very tight stricture, I have published in Endoscopic International 87 patients. Out of them, if I'm not wrong, 17 was pancreatic stricture. Once the wire is crossed and I am not able to negotiate, I using the pure current over the wire, I cut through the strictures, both in the biliary stricture as well as pancreatic stricture. But now my suggestion, those who are doing ERCP, use the hurricane balloon or use the pancreatic dilators. That is more important rather than using the Sohindra for burrowing the stricture. But if you want to do it, you can do it, provided your wire should be across the stricture. You should not use as a blind.
Thank you, Dr. Sabeen. Dr. Madhu Shashikaran from Trivandrum. Dr. Madhu?
Hello, good evening, sir. Sir, one doubt I had. To focus this ESWL, do you use this NBD catheter in the PD and localize it, or you just go ahead blindly?
Yeah, I think again a very good question. And I have mentioned during my lecture, those radiolucent stones. We use the nasopancreatic duct pancreatogram on the table. Otherwise, radio-opaque stones, we check under fluoroscopically before ESWL. If the stones are radio-opaque, then we send them for the ESWL. And we don't use the nasopancreatic catheter for that. Our entire purpose will be futile in the radio-opaque stone if you use the nasopancreatic, because then you are subjecting these patients for the ERCP.
Okay. One more question, sir. Yeah, you said that you will dilate the stricture with a CRE balloon. How frequently hurricane balloon. So how frequently you encounter a pancreatitis in such cases? I have a very, very difficult PD stricture. I'm not able to pass any stent beyond 7 French. I tried multiple times. So I am just a little bit scared to dilate the stricture with hurricane.
No, I absolutely agree. And I always suggest that biliary stricture, it is always better to go slow. Dilate with the 4 mm hurricane balloon. don't rush with the 6 or 8 or 10. I think 4 mm balloon, you will be able to negotiate the 10 French stent.
So the patient is forcing me to put the bumpy stent for him. That I don't know whether it will be useful for him or not.
I have no experience, frankly speaking. I have
Yeah.
never placed, but I have read the literature. There are few centers in India, they have placed 1 or 2, but mind it, bumpy stent produce another stricture because they remain in the pancreatic duct for a longer time. But I have no experience, frankly speaking.
Okay, sir. Okay, thank you.
Thank you, Dr. Madhu. There are some questions in the chat box also. Those who are having questions can raise their hand. Dr. Shabir Sheikh has asked about hints on pediatric age ERCP and duodenal bulb deformity also.
What was the question? Pediatric?
Pediatric age ERCP. What are the hints? What are the tips?
In pediatric cases?
Yeah.
There's no significant trick. What you require is a patient should be good enough to have a ERCP scope can go inside. So roughly around more than 8 years or 6 years. Otherwise, small children, it is not possible to do it. You may require a diagnostic ERCP scope, which is 11.6 millimeter, but I think they are stopped by the Olympus. Now we don't have. Fuji Pentax has a pediatric scopes, and the most important thing what I have done a few cases is the duodenum, and the manipulation of the scope is sometimes little difficult because from esophagus to the duodenum, generally in the elderly people, there's a long loop happen along the greater curvature of the stomach, and there's a ease. In the children, sometimes it is difficult. So be gentle. The risk of the scope in related trauma will be there. So you should be gentle because the mechanical injury from the scope might happen in the children's. Any words you want to say, Dr. Gunjan? Or is that okay?
I think it is okay, sir. I think.
One person has raised his hand. Shafi Sam, can you please unmute?
Yeah, hi.
Okay.
Doctor, I have a question in which my name is Shafi. I'm from Malaysia. Okay, I would like to ask from literature, as far as I'm updated, the latest literature says that for pancreatic stricture, the stent that should be placed should stay at least for about 4 to 6 weeks, according to the latest literature. But as what you say that it should be removed by 7 days. But the literature says that the inflammatory changes can occur higher whenever we remove the stent earlier. What's your comment on that? Is it based on your experience or based on the literatures or the latest literatures? This is as far as my reading that I got.
What I understood from your question is, when we put a prophylactic pancreatic stent,
yes,
it should be removed within 2 weeks.
But the literature mentioned about 4 to 6 weeks. So which one is it? Is it?
I think 2 weeks.
2 weeks. Okay.
Dr. Gunjan, what is your message?
As early as possible should be removed if it is prophylactic.
Yes.
Okay.
Dr. Sabine has raised her hand once again. Dr. Sabine, once again, please.
Yeah, I have one more question. That you say that when we want to remove, it is possible to change a lamps and place plastic stents. So what is your technique for doing that? When you remove the lamps, do you go for a wire insertion under EUS, or would you just do it directly with a therapeutic scope, placing a wire in, coiling it in, and then exchanging double pigtail? What's your technique for exchanging the lamps for double pigtail?
Yeah, I think it's a very good question, Dr. Sabir. So 2-3 things which I want to highlight in this. The concept of early lamps removal come from the sham studies that they have shown if the lamps remain for more than 3 to 4 weeks, the risk of complications are more. But in the real life scenario, when you remove the lamp, 80% of the time the cavity collapses and you hardly find any place to put another plastic stent. The message which I want to give by that, if patient still has a large cavity, you can take your upper GI scope inside, because why you are removing the lamps? Generally, when patient is asymptomatic, when it comes, you remove the lamps, you don't require anything. The risk of disconnect pancreatic duct syndrome, if we want to discuss that, I will be happy to discuss that part. But majority of the time, the cavity collapses and you hardly find any place to place the stent. If there is a cavity, then the upper GI scope, which is required for lamps removal, through the same scope, you put a guide wire over a guide wire, you put a double pigtail stent. You don't require to do anything. Now the question comes, in a patient of acute necrotizing pancreatitis with the walled-off pancreatic necrosis, when you remove the lamps, there is no cavity. 3 important studies, one from AIIMS, one from AIG, one from Mumbai, they show that 5 to 7% of the patient has a recurrence of collection. But out of 5 to 7%, a small subset of these patients become symptomatic. Rest of the time, they are asymptomatic collection. You don't require these patients to do either a ERCP stenting, or when there is no cavity, you can't do the stenting through the lamps route also.
Right. Thank you.
If there is a route, you take upper GI scope and you do it.
Right. Thank you.
Thank you, Dr. Sabin. Dr. Angharur from Bangladesh. Dr. Angharur, can you please unmute?
Hello, can you hear me, sir?
Yeah, we can hear you.
Oh, okay, sir. I am Dr. Anar Rahman from Bangladesh. Now I'm currently in Bangkok. I'm the fellow of HBP in NCI. I'm a surgeon. Rajesh Puri, sir, I have a question for, basically as a surgeon, I'm asking the question. 2 questions from me. Number 1 question is, in my practice lab in Bangladesh, I have found lots of pancreatic stone and lots of biliary calculus pancreatitis. That means the patient comes with biliary calculus with pancreatitis. And you said that the patient has developed calculus pancreatitis. If most of the cases, no ERCP is indicated. So we'll give conservative treatment and then later on we'll do it. In what we learn in surgery textbooks, that calculus pancreatitis, if it is from the gallbladder stone in the CVD, we should remove it early. Different textbooks. But my question is that if we found what I did in my practice life, I do conservative treatment for the patient and patient gets well. And later on, I decide what shall I do? Should I do ERCP or should I do colorectal by laparoscopic? Sir, is there any indication when I do ERCP and retraction of the lower CVD stone, or we can do the laparoscopic colorectal as well as colonoscopic removal? Which you prefer for that?
Yeah, very good question, Dr. Rahman. I think very valid point. I would like to give the clarification by 3 means. As during my lecture, I said, acute biliary pancreatitis, ERCP to be done only if there is a cholangitis. If there is no cholangitis, no ERCP. If there is a CVD stone without cholangitis, you wait till the patient is become stable. And before cholecystectomy, you do an ERCP and you do a cholecystectomy. There are 2, I think, head-to-head trial recently published last year where people has done the laparoscopic cholecystectomy also.
Yes.
But I think till now, the data is more in favor of doing the pre-cholecystectomy ERCP and subjecting these patients for cholecystectomy. And in the practical real life scenario, I will tell you, majority of the laparoscopic surgeons, they are not ready for cholecystectomy because they hardly find now the indication for doing this. So in the real life, even the few centers, the literature wise, they have shown that doing the laparoscopic bile duct exploration is quick and equally effective like an ERCP. but I am talking in day-to-day life. I don't think all laparoscopic surgeons are tuned to do a laparoscopic CBD exploration. It is better to do a 5 to 10 minutes of ERCP, which is safe, effective, and highly successful. And then you can do the laparoscopic cholecystectomy.
Sir, question is that we can do ERCP and lap cool in the same sitting? Same sitting?
Yes, yes, we should. We should.
Okay,
We should.
okay, sir.
And
And then
even
and
in
there's any
the
indication for stone size? Stone size. For example, the stone size is more than 1 cm or nearly 2 centimeter. In that case, we can do ERCP and lap cool in the same sitting or different approach, sir?
same sitting.
Same sitting. Okay.
The-
Sir,
the
last question is
The two things which I want to tell you, because a lot of audience are surgeon. Now the concept is in mild pancreatitis, in the same setting of the hospitalization, patient go for a surgery. You don't wait for the 6 weeks or to settle. Unless until patient has a moderate to severe pancreatitis, cholecystectomy to be done later. If patient has a CBD stone and mild pancreatitis, you remove the stones, and the same setting you do a cholecystectomy,
okay. So
irrespective of the size of the stone.
okay, thank you, sir. Last question is that I have one case scenario. A patient comes to me with severe chronic pancreatitis. For a year, he attacks about 2 to 3 times. And last time he comes to me, I found that there is a stone stuck in the pancreatic duct neck, a big stone neck, and compression of the lower CBD. There is a stricture in the lower CBD. So at firstly in the MRCP, they suspected about IPMN, intrabiliary neoplasm. They suspected, and later on it is excluded that he had a stone impacted in the neck of the pancreas, which compresses the lower CBD, and it got strictured. So my question is that we should go for endotherapy like ASWL for the pancreatic duct stone, but for the stricture of the CBD, it will automatically go out, or we should do stent for that?
Yeah, a very good question, sir. If patient has a symptomatic biliary obstruction,
Yes.
or if the CBD is, another literature says, if patient has cholangitis, symptomatic biliary obstruction, more than 10 millimeter, or the alphos and gamma GT is twice the upper limit of the normal, it is always better in the first sitting, you should put a biliary stent. Does
Okay.
it automatically resolve or not? Let the nature to decide. But at the
Okay.
time of intervention, when you are doing the pancreatic endotherapy, a symptomatic biliary stricture needs to be tackled at that time rather than waiting. The reverse of that true is, like many of the time patient is a walled-off pancreatic necrosis with a CBD obstruction. Then you do a treatment of walled-off necrosis. You don't try to treat the CBD obstruction. But in cases of chronic pancreatitis, when there is a CBD obstruction, you should not only treat CBD, the pancreatic duct, you should treat the CBD simultaneously.
Okay. Thank you. Thank you, sir. Thank you very much, sir.
Rahman, related to the same scenario, there is a question from Dr. Shabir Sheikh. How do you diagnose or rule out cholangitis in the setting of acute pancreatitis without infection?
Yeah, I mentioned in my slides. So that is very important actually. When a patient of severe pancreatitis came and has a fever, has a tachycardia, tachypnea, bilirubin, but when you repeat an LFT on the day 2 and you find it has gone up, patient high-grade fever is persisting, so that is a clinical call you take. CBD is dilated, stone is present, and patient has a rising bilirubin, it is better to do the ERCP in that time. One more thing, what I have seen, Deepak is also here. When I was going through this literature, people talk in first 24 hours, there's a lot of duodenal wall edema. I think that is not true. What is the duodenal edema is more after 3 to 4 days. Within first 3 days time, the duodenal edema is less. So try to use that window and do the early ERCP if you suspect a cholangitis. And the indication is leukocytosis, rising bilirubin. If patient comes with the bilirubin of 3 on the day 1, and we suspect a cholangitis, but day 2, we find the bilirubin has come to 2, the chances of cholangitis is not there. Fever is a part of acute necrotizing pancreatitis. Bilirubin jump to 4 or 6 or 7. We know that patient has cholangitis, it is better to intervene.
Yeah. Another, tell.
Dr. Deepak, please.
Progressive rise in transaminases and bilirubin. Both the things will corroborate the patient has cholangitis. And mind it, acute pancreatitis is not caused by the large stone. It is always a small stone. So there are chances the stone will pass most of the time.
Yeah.
74% of the time stone migrate of its own.
Yeah. Dr. Karna has a question regarding the size of the double pigtail plaque stent in the case of symptomatic pseudocyst.
Size of the double pigtail stent. I always use the 10 French. I always use. People has tried with the 7 French. Literature talk about 7 French, but in my practice, I have never used 7 French. I always use 10 French pigtail stent.
And Dr. Sabina has another question regarding hydrogen peroxide in necrosectomy.
What?
Hydrogen peroxide in necrosectomy.
Okay, so I think there's a recently published paper shows there's no advantage of hydrogen peroxide.
How long will we keep the plastic stent in pancreatitis drainage for access? How long?
Yeah, again is a very good question. So this is important. The pancreatic stent, you have to see that are you dealing with the acute pancreatitis? Are you dealing with the chronic pancreatitis? If there's a chronic pancreatitis along with the stricture, tackle the pancreatic duct stricture first before taking out the stone, taking out the stent. If patient has a walled-off necrosis, disconnect duct syndrome, I keep the stent for years together. If patient has a normal pancreatic duct, if you find on MRCP and patient has acute necrotizing pancreatitis, after that the walled-off necrosis has happened, you can remove the stent. So in chronic pancreatitis, tackle the chronic pancreatitis first. In acute pancreatitis with the fluid collection, look at the pancreatic duct. If disconnect is there, keep the stent for longer time. If no disconnect, you can remove the stent.
Yeah, Dr. Sabine has got another question regarding, do you exchange metal lamps to plastic under US or duodenoscope under fluoro?
I take upper GI scope only. I don't use duodenoscope. I don't use US scope. Upper GI scope, which is used to remove the lamps, the same scope is used to put the plastic stent.
In a papilla with benign stricture, what is the suggestion for avoiding chronic pancreatitis?
In a?
Actually, that question is not clear to me too.
Can you again ask? I will tell you in a biliary stricture, how to avoid pancreatitis.
Yeah.
So I think this is very good thing which I want to tell you. I don't know if it's written in the literature or not, but what I've learned from my seniors, in a lower end CBD block, sometimes it is difficult to cross across the lower end CBD stricture, and you keep on going to the PD. So my suggestion to is inject small amount of contrast. Yes, people will talk about cholangitis or so, and that will depend upon the expertise available. In my practice, in lower end CBD stricture, I don't fiddle much with the wire. I inject small amount of contrast, and under fluoroscopic guidance, I try to manipulate my wire into the bile duct. And if the dye goes to the pancreatic duct, I know that second time, if my cannula and wire is in the same direction, I don't keep on injecting. So I opacify the proximal part with a very small amount of dye and manipulate my wire accordingly.
Yeah. There is a question from Dr. Dattaram. He is from Andhra Pradesh. Dattaram is a surgical gastroenterologist. He's asking about what are the infectious complications seen after endotherapy for CCP. Do you come across pancreatic abscesses after endotherapy?
No, literature it is available, but I'm not, frankly speaking, it's not. Actually, I will tell you, I born and brought up in a unit where the therapeutic ERCP was very good. So truly speaking, I'm not over exaggerating. My learning curve of ERCP started after 10 years. I observed for 10 years. I have not been given scope for 10 years. I was just giving sedation and watching people doing. And my mentor was very good in ERCP. So touch wood, I don't come across.
Dattaram has got another question regarding the selection of cases. Dattaram, Are you there? I can unmute and ask the question. He's a surgeon. Datta has gone, I think. Dr. Dattaram, he's there. I'll unmute you, Dr. Datta. Dr. Datta.
Yeah. Sir, I'm here, sir. Thank you, sir. Thank you so much. Excellent talk, sir. Sir, regarding the infectious complications, I had 2 occasions where I had to go in after endotherapy, and I couldn't, like, there's a bad pancreatic abscess. The CT before surgery could not pick up. That's the reason why I asked the question. Another thing is, good to hear that you haven't come across in your center, sir. But I had a terrible experience with that patient. That's why I asked. And second thing is, sir, you were like in your talk, you kept on telling me, you repeatedly told that we had to choose right patient before endotherapy, and some patients for exclusive surgery as the first choice. So, how many of your patients go for surgery after endotherapy, sir? Like
in chronic pancreatitis?
Yes, I'm talking about chronic CCP only, sir.
So to be very frank, I will tell you, upfront, if the pancreatic duct is studded with the stone, we send for surgery, number 1. And number 2, when patient is not responding with endotherapy, our surgeon says he is not going to respond with the surgery also. We take in the judiciously decision. We don't subject all patients. If patient comes with the large duct, which is tail is stones are there, we don't try endotherapy and do it. We don't do it. And second, you talk about the pancreatic abscess formation. I do agree. It will depend upon the 2 important things. Number 1, what accessories are you using to sterilize or not? How your technician has handled those accessories, and how badly the pancreas has been manipulated. Because truly speaking, I'm not talking about you. I'm not talking about anybody. No personal thought. But many of the places, fluoro are not good. People don't take proper pancreatogram. Assistant is new. Many of the time, people as a car driver who is your assistant, and he is pushing the guide wire very firmly. You puncture the side branches, then the risk of pancreatic abscess and the complications are always be there. In a good center, after a good training, good fluoro, good assistant, if you do judiciously, risk of complication goes down. Otherwise, yes, severe pancreatitis, I've seen the death because of pancreatitis also. Not 1 or 2. Many patients come from different center where the acute pancreatitis, patient goes to the severe necrotizing pancreatitis, and patient dies also. Multiple collections happen. So that's not, nothing is uncommon. It is seen. So the most important thing is we should identify our ability. We should identify everything what is available, and it is not the one-man show. Your technician should be trained. Your fluoro should be trained. Everything should be trained. I will tell you my beginning of my career, when I was doing for the smaller places, patient was referred as a chronic pancreatitis. When you go inside, you try to see it was a pancreatic malignancy. It was not chronic pancreatitis. So the quality of investigation matter. Then the fluoro machines. Majority of the places people do under the orthopedics fluoro, which stop within 3 or 4 seconds or 10 seconds. You're not able to see. The quality of fluoro is very poor. So all these complications are there. I also has the bleeding. I remember when I was going to the small places, I stay overnight because doctor who has called, he don't know how to do the side wing endoscopy. And the post-EPT bleed has happened, then you are worried. If you come back and the night the patient is going to bleed, how you are going to tackle? So what I'm going to talk about the ideal scenario. So what is important is endoscopic environment. What is required is a good accessories. What is required is a good technician. What is required is a pre-procedural investigations. And what is required is your own hand. If you take care of these precautions, risk of complications are very less. I'm not saying a complication cannot happen. As the standard of endoscopy is going to down, the risk of complications are more and more and more. Is that right, Dr. Deepak?
Good endoscopic setup is very important, including the multidisciplinary team.
Yeah. Thank you, Dr. Datta. Dr. Eid Tirami from Morocco. He is our ambassador in Morocco. Are you there? Can you please unmute? If he is not able to unmute, we will go to the next question. Regarding do we need to dilate up to 10 mm with the CRE balloon always, without considering the period diameter in the head of the pancreas?
No, I said that. The diameter of the balloon will be decided about the proximal dilated pancreatic duct. I don't dilate every time 10 millimeter, number one. Number second, I'm not dilating the pancreatic duct stricture, I'm dilating the papillary orifice. So I always keep a very minimal amount of balloon inside and then dilate. We don't have a dilated, dedicated biliary and the pancreatic balloons. If we have a small size of the balloon, which only remain 1 centimeter inside, you can take